Thank you, Jarek, and thank you for the invitation to speak today. I hope that many of my comments in this talk will integrate well with our first two speakers also. But I wanted to start, sorry, how do we advance?
Right.
Oh. No, sorry. Oh, sorry. Okay. My objectives today are to review the role of quantitative JAK2 allele burden testing in MPN diagnostics, and then to review our Hopkins cohort and the PV subset of that to really elucidate genetic modifiers and stem cell burden as it relates to disease. I would like to start with a patient. I think most of us, while we talk about genes, we're really caring for patients. This is a 48-year-old woman who was referred for erythrocytosis, and she had very typical hematology indicative of an MPN, with a mildly elevated white cell count, a very elevated hemoglobin, elevated platelet count. She presented with a large spleen, a very low EPO level, and a bone marrow exam here indicating dense hypercellularity and atypical megakaryocytes. She had a karyotype which showed 4 of 50 cells with a 20q deletion at the time of her presentation. Her presentation was in 2003, so this predated the JAK2 mutation discovery. She subsequently was found to have V617F. What I have outlined here is over the first roughly 10 years of her disease, really what occurred. So she had a clinical diagnosis of Polycythemia Vera that no one would dispute in 2003. But you can see over the arc of the 10-year course, her white cell count started to trend down. Hemoglobin, while she was very phlebotomy dependent, you can see in the last few years here, she started becoming frankly anemic and lost her phlebotomy requirement. And then platelet count is typically tends to rise with PV over years. We had this decline in platelet count, and then unfortunately an increase in MCV over time, indicating that really her clinical disease changed quite slowly, but perceptibly over the years. This table just shows her actual diagnostic year was 2000, where marrow, as I mentioned, was hypercellular with those morphologic changes, and she had 8% of her karyotype with 20q deletion. By 2012, she had developed the macrocytic anemia, and now on repeat cytogenetics, she had 100% of her karyotype had the 20q deletion. When we were starting to measure allele burden in 2005 and then 2012, we have these quantitative measures that also increased. So I just wanted to step back and really look at the last century, both in genomic discovery and compare that to progress in PV. The idea of a chromosome was really postulated by Sutton and Bovary in 1902, and the concept of gene finally in 1909. We have Rosalind Franklin's double helix X-ray crystallography in the middle of the century. And then really the human karyotype was finally understood to be 46 somatic chromosomes. In 1957, it was still disputed even to the middle of the century how many somatic chromosomes there were. Important, of course, to cancer was the Philadelphia chromosome discovery, the first fusion chromosome in 1960, and then, of course, the resequencing of our genome. And P. Vera really benefited and sort of follows in lockstep with the last century also. The first English language description of polycythemia was Osler in 1903. Damashek, by the middle of the century, postulated these family of MPNs. Janet Rowley showed the important association of the Philadelphia chromosome to the disease entity, CML. And then, of course, the BCR-ABL in the 80s. The cloning of JAK2 was in 1998 and actually followed quickly by a fusion gene incorporating TEL and JAK2 in a human leukemia. And then, of course, in 2005, the JAK2 discovery. So both genetics and our own disease in 100 years have gone from description of clinical entity to molecular classification. So we have had 10 years now of the JAK2 discovery and this knowledge to benefit and to both help us understand the cause of these diseases and also the variation associated with it. The JAK2, of course, is an acquired somatic mutation with enhanced kinase activity. Of course, the 99% of the JAK2 lesions are V617F, although there are some others. These activating lesions never spontaneously resolve, and clonal expansion of the JAK2 mutation positive cells occurs. And I think from the talks we've already had this morning, this idea of clonal outgrowth is certainly marked by JAK2 particularly. The JAK2 lesion gives an advantage in signaling through a normal signal transduction pathway. And so the clones that have JAK2 are selected for. And interestingly, with JAK2 mutations, 9p-UPD, as Jarek mentioned, is very common where you get a duplication and therefore a double dose of the JAK2 mutation, generating many clones then to be homozygous for the JAK2 mutation, which adds an additional layer of complexity to the burden of the disease and is really unique to JAK2V617F in that 9p-UPD occurs, well, you'll find out later that really virtually in every patient who develops the JAK2 mutation. So we've seen a lot of cartoons and Venn diagrams, and I have my own here this morning, the JAK2 mutation and the MPN spectrum. So here in black, if you can imagine, if we could gather all the clinical phenotypes associated with the JAK2 mutation in this black circle, clinical entity, Polycythemia Vera, really makes up about half of all JAK2 mutation. We also know that essential thrombocytosis and primary myelofibrosis, about half of those patients have JAK2V617F as their founder. A small subset of those may evolve into AML. And then we have unusual phenotype of refractory anemia with a ring sideroblast and thrombocytosis that can be manifest by the JAK2 mutation. But already within one lesion, we have so many different phenotypes, and this evolution between phenotypes, as you can see, we know that many patients with ET can evolve into PV. PV can evolve into myelofibrosis. So there's quite a bit of variability induced into this system despite the same initial lesion. We know that gene dosage has a very important effect on phenotype. Age and gender also seem to influence this, and of course in phenotypic evolution. I also wanted to just compare the CALR mutation. CALR is a more recent discovery, and yet within just a couple years of CALR, we have a similar Venn diagram to generate from this. Again, if you can imagine all the CALR positive patients in this black circle, we know that there's roughly half will have ET and half will have myelofibrosis, and then this overlap in a small subset with AML. I've put PV way off to the side here because there are reports that CALR can be associated with polycythemia vera. I haven't seen that clinically. I wonder if anyone in the audience has, but there are reports that there are patients that have CALR as their driver mutation in PV. The gene dosage effect in the CALR lesion seems to be much less than in JAK2V617F. UPD involving the CALR locus has been described, so you can get variation in clonal dose with CALR, but at a much lower frequency than with JAK2. But certainly, again, age and gender and phenotypic evolution influence whether patients evolve into CALR from ET to MF. And so that is similar and analogous to JAK2. So I want to move now back into a little bit of the population study we've done in our cohort at Hopkins. We have 607 patients that we've phenotyped after the JAK2 discovery, so 2005, and follow semi-annually. About 15% of the patients are enrolled at diagnosis, although most had disease durations of about 8 years at diagnosis. And what we're doing with this cohort is to try to understand causes and consequences, risk factors, and outcomes in this cohort. Why do people develop polycythemia vera? Well, these again are why, the same question you could ask of why does someone develop MDS or any clonal disorder. There certainly are risk factors in addition to acts of God type of causes. We certainly know, have come to understand that JAK2, TERT, MYB, and ATM haplotypes have some role in acquisition. And the very exciting paper that Dr. Hexner brought up about another complex lesion that may serve as a predisposition lesion around the JAK2 locus. There's been questions about heritage, and Ashkenazi heritage may be a risk factor or an increased predisposition. Certainly about 10% of individuals with JAK2 will have a family history of MPN. And then my own favorite is a study in France where they identified blood donation as a potential risk factor for developing a polycythemia vera. It was a study where they looked at P. vera patients in occupation, and they found that blood donation was overrepresented in this group who developed polycythemia vera. Environment is certainly important, and there was an outbreak of polycythemia in Hazleton, Pennsylvania in the 70s and 80s, and that has been investigated extensively by the CDC to try to understand what was if there was an environmental cause behind that. And I think the upshot of that study is still pending. And then, of course, we have concerns does P. vera and acquisition of the JAK2 mutation represent a cancer predisposition syndrome? And there are various studies that look at other cancers in patients with polycythemia vera, and melanoma, breast, and bladder cancer do seem to be overrepresented in those patients. Now back to the genetics of this. The JAK2 mutation really brought in the concept of the allele burden, or the burden of disease. And why was that? Was because very early on in the JAK2 discovery, it was recognized that some patients had 100% JAK2, meaning no residual wild type JAK2 locus, while others had very low levels of JAK2. And that, again, is introduced both in the amount of burden, or the amount of clonal expansion, and also whether the clone has a heterozygous or a homozygous JAK2 mutation. And that's how that can introduce this variability. So in this study, we did peripheral blood JAK2 allele measurements, percentage here on the y-axis. And you can see in ET compared to PV and myelofibrosis, the distribution of the JAK2 burden is significantly different, whereas between PV and MF, they're more similar. So again, some variability in burden related to what percentage of the clones may be homozygous and how much expansion there is. When we look prospectively then over time, so these are just PV patients, and over here are measurements we've made in individuals, and on the x-axis is the disease duration at the time of their measurement. The y-axis is the allele burden. You can see that an individual colors represent an individual patient. So for instance, this patient in gray here, these are multiple measurements between years 22 and 32 of their disease, of their JAK2 allele percentage. You can see for the whole group over time, the JAK2 allele percentage does seem to increase, although there are many patients that maintain this relatively low or constant burden over time. And again, showing that the allele percentage is a dynamic variable over time. So at diagnosis, the typical allele burden average is about 60%, yet by 10 years, that's increased at about 75%. Associated with this is a change in natural history. So what I have here is from these PV patients that we've followed from diagnosis to then 10 years into their disease. We have the percentage of patients who were PV at diagnosis, and then the percentage of patients who had antecedent ET or had ET at their diagnosis. After 10 years of JAK2, you can see their phenotypes have changed. 67% now of this same group has maintained PV, but some have moved into myelofibrosis in gray, a small percentage of AML. And some patients still are in their ET phase that they have not moved into to polycythemia vera, and that in this cohort, that occurred at year 15. So again, time seems to be an important factor in determining natural history. When we talk about transformation or PV, what risk factors do we have? Well, we certainly age, and we've heard a lot about age, and Dr. Hexner mentioned over 50 or over 60. When is age really that important? And certainly in JAK2 disease, age is very important. So median time of transformation to MF is 61 years, whereas AML at 71 years. Allele burden, so how much JAK2 you have seems to be important. Certainly post-PVMF, very high allele burdens, average of 80%, and post-PV AML, also very high allele burdens. And we know that the JAK2 allele percentage seems to serve as a risk factor for developing AML, MF, just splenomegaly, or even an elevated white cell count. And then time. Time itself is important to transformation, and again, time gives you time for genomic instability to occur, as aging does. And we know that disease transformation occurs on average at 8 years for post-PVMF and about 10 years for post-PV AML. So we have these basic factors: age, allele percentage, and time. But of course, these may be just modified by acquisition of genomic lesions. That's what we really need to look at. I just wanted to share with you the importance of the allele burden to phenotype. In this group of patients, we have their ET phase as they've then transformed into PV, and you can see that the transformation of ET to PV does associate with an increasing allele burden, so that as the JAK2-positive clone expands in ET, that is associated with developing polycythemia vera. In contrast, when we have patients transforming from PV to MF, so we have their PV phase and their JAK2 allele burden compared to their MF phase, there really does not seem to be an increase in JAK2 allele burden. It was high to begin with, and it remains high during their MF phase. And then finally, we have a number of patients where we followed during their PV phase as they've moved into AML. And again, they tend to have high allele percentages, long disease durations, but again, not a dramatic change at the time of their transformation, indicating additional factors that must be responsible for this transformation. In the first 10 years of our study, we really only had karyotype, and then in collaboration with YARC, we've had SNP arrays to assess the genomic complexity of patients. So what I have here are 125 PV patients where we have listed their patients who were still in the PV phase, so each line across represents a patient. Then we have a number of patients who went from PV to MF, and again, each line across is an individual patient. Some patients who transformed to MDS, and some who transformed to AML. The intensity of the color here relates to the elevation of their JAK2 allele burden. So the very dark color means 100% burden, where a very light color means a lower burden. And then over here is the karyotypic complexity. And again, the darker the color, the more complex the karyotype. So for instance, most of the chronic phase PV patients have no additional karyotypic abnormalities, despite having fairly high JAK2 allele burdens. But as we move into MF, we see more karyotypic changes and complex karyotypes, certainly as we move to AML. What are the genomic lesions? So certainly JAK2V617F, that's in about 98 to 99% of our patients, whether they're PV, post-PV, MF. In myelofibrosis, primary myelofibrosis, for comparison, that's only in 60%. 9-PUPD, something that we can't get through common standard cytogenetics, but if you have access to a SNP array, 9-PUPD occurs in about the majority of PV and post-PV MFs, again, indicating the homozygosity. Trisomy 9 is much more, is probably the most common lesion, genetic lesion in post-PV MF, really never found in chronic phase PV and fairly frequent in post-PV MF. And then our other chromosome deletions of 13q, 1q, 6p, 20q deletion, and 11q deletion. These were the most common ranked lesions after 9q-UPD in the post-PVMF cohort. I just went out, of course, what do these regions subtend? We know that certainly 9q-UPD always harbors a JAK2 mutation, so there's always a V617F mutation. We know that the 13q deletion harbors BRCA2, RB, and SETDB2, sorry. And that, again, these are lesions that we understand are cancer predisposition lesions or genomic instability alleles. So their deletion seems to probably indicate some causal association. Importantly, the 20q deletion often harbors ASXL1 and our other well-known friends here that we've been talking about this morning. So that these deletions subtend the same chromosomal lesions that we've been discussing earlier today that are lesions associated with progression. Earlier in 2014, Wang described 31 chronic phase PV patients with whole exome sequencing, and again listed the most common lesions, and you can see here we have ASXL1. Interestingly, NF1, the neurofibromatosis gene, was present in not an insignificant group. Then we have, again, TET2 and these others that we've already discussed this morning. These were listed as chronic phase PV patients, although I do wonder whether some of these were actually evolving or were in a more advanced phase of their disease. Let's get back to our patient. As I mentioned, our patient had 9q-UPD. She had the 20q deletion, which in the rest of our cohort is much more frequent in MF, and whether primary or post-PVMF. She, by SNP array that we have as a clinical assay, was also found to have a 6q23 loss and a 6p11 loss. And the genes subtended in these regions, MYB is in one, and then in the 6p region, there's many genes that are important that are deleted there. We also, at Johns Hopkins, more recently have had access to the Genoptics panel looking for mutation analysis. And I just note here that in the Genoptics panel, she was positive, of course, for JAK2, but these other lesions that panel tests, ASXL1, RUNX1, EZH2, ETV6, she was negative for mutations there. So again, this is where we are in being able to characterize our patient. So the lessons in PV is that mutation prevalence and complexity of karyotype increase with transformation to MF or MDS or even AML, and that these really are causative lesions. These lesions drive this transformation. Microdeletions of the karyotype can sometimes point to phenotypic drivers. We had one patient who developed a deletion of PIG-A and therefore developed PNH from their chronic phase disease. I mentioned UPD. 9q-UPDs follows by nearly every chromosomal region is the most common region. UPD tends to evolve over time so that multiple clones come out with different regions of UPD, and if those regions of UPD subtend lesions with activating mutations, that clone then takes on a new feature of malignancy. In my practice, I've never seen the JAK2 mutation go away or spontaneously remit. The only time I've seen it go away when it was pushed out, as Dr. Masajewski mentioned, by one patient developing CML who developed BCR-ABL, which basically expanded out of JAK2, pushed JAK2 out, and other patients, another patient who developed CMMOL and a different karyotypic lesion that, again, pushed the JAK2 lesion out. So I just want to summarize here with the stem cell complexity. I know I've gone a little bit over here, but when we think about, well, where does this burden coming from? What we've been able to do is look at individual cells and sort them by a stem cell phenotype, and then what these pie charts show are the JAK2 genotyping of individual cells expressed as a pie chart. So for instance, in this ET patient, the majority of the single cells that we genotyped for JAK2 of these stem cells were wild type, meaning they were JAK2 wild type. A small portion were heterozygous, and then a smaller portion was homozygous. So this is a patient who has ET, and if we look at 100 of their stem cells, the majority of them are JAK2V617F negative, but in that same person we have some cells that are heterozygous and some that are homozygous. In contrast, in PV, when we look at an individual patient at the stem cell level, we still have wild-type cells, but much larger proportion of JAK2 homozygous and JAK2 heterozygous. And then in contrast, here's an MF patient, a primary myelofibrosis patient. Again, we still see wild-type or JAK2 negative cells, but again, homozygous and heterozygous. In every patient with JAK2 that we've studied, regardless of their phenotype, we can always find wild-type cells or JAK2 negative cells at the stem cell level. And in every patient, regardless of their phenotype, we find homozygous cells. We've done this in about 50 patients now with a variety of lesions. So this stem cell basis of that's where the lesion occurs, that's where homozygosity occurs, and that you still have cells that at least do not have that initial driver mutation is present in all patients. So you can understand why a patient may develop a JAK2 negative clone that comes out of their so-called JAK2-positive chronic phase, because they harbor JAK2 negative clones and clonal diversity at their stem cell population. And this is just with respect to JAK2V617F. You can imagine other lesions. There's probably a huge number of permutations and combinations of lesions in an individual with a disease. So the stem cell lessons that we have here, mutations, deletions, and UPD occur in these primitive stem cells. 9p UPD occurs in the primitive stem cell, and it occurs repeatedly. So, right, you may have a UPD region that occurs at year 1 of the disease, and then a different JAK2 clone may develop UPD with a different size at year 10. All these lesions are long-lived, the stem cells are long-lived, and they only leave when other clones dominate. So we've been able to show that all of these lesions occur at a very primitive stem cell. And what accounts for the acquisition of these lesions? Well, certainly aging. The JAK2 mutation itself may induce genomic instability, host factors, male sex, familial predisposition, DNA repair defects, and exposure are all confounders to getting these. Back to our patient, I just wanted to show you her progress. So again, we should have been very suspicious at the beginning of her diagnostic year that she had this 8% 20q deletion. That really would not be typical of someone with a chronic phase PV, and you can see over time her 20q deletion tended to dominate, and then she developed additional lesions, 6q deletion and 16p deletion. And this was associated with morphologic change in her marrow to a more dysplastic change, the development of transfusion dependence, and then the need for therapies to address this change in her disease. So we used thalidomide for a year to try to support her anemia, moved her over to Jakafi, and then ultimately we're pursuing transplant. So I want to close with the JAK2 breakthrough has redefined the epidemiology of an old disease, reclassified the disease from disorder to neoplasm, and has recalibrated our treatment expectations. So the therapy must be age and goal adjusted, and we have to recognize that these additional lesions and the mutational burdens of these lesions should be incorporated into disease monitoring so we can better look at prognosis and interventions. And further, we have to reassess the roles of age, gender, time, molecular lesions, and genetic background as genomic and disease modifiers. So I'll finish there.